Okay. Good evening, everyone, and happy Diwali to one and all who celebrate this festival from all of us here at Bangalore Hellenic Sciences and Bangalore Skull-Base Institute. Today, I come to you with another webinar in our series of webinar presentations, and today my topic is the evidence-based management in Meniere's disease. I am Dr. Rakshita Kamath. I am a consultant ENT surgeon here at Bangalore Skull-Base Institute, and I will be taking you through various aspects of Meniere's disease and also different aspects of the management protocols that we follow in the ENT fraternity to manage this particular condition. Now, in 1861 is where Prosper Meniere found out that the site of the pathology of this particular condition was the labyrinth, and in the 1867 Pulitzer, along with in the 1871's NAPS, is when they were able to really put together the fact that it is because of a hydrops-like condition, and it was NAPS who called it the oral glaucoma. Now, although in 1926 Portman and 1930 Dandy were working on the principles of management of this particular condition, it was only in the 1938 when Yamakawa and Hall-Pikey were able to talk about the pathological findings of the endolymphatic hydrops, and it was in 2007 that the Naganava was able to give us the details about the endolymphatic hydrops seen in the gadolinium enhanced MRI. However, through all of this history, we still do not know the exact etiology, and it still remains elusive to all of us. Now, the definition of the disease predominantly talks about the membranous inner ear disorder with characteristic features of vertigo attacks, fluctuating hearing loss, tinnitus, and oral fullness. Now, for the most part, this particular disease is idiopathic, and pathological correlation of this disease is associated with hydropic distension of the endolymphatic system. Now, in this particular image, we can see that the endolymphatic sac in the inner ear is generally healthy and is seen at a particular caliber, but whenever it is in the Meniere's disease, you can see proper backed up filled fluid which leads to swelling and pressure in the endolymphatic sac. Now, moving on to the variants that we see in Meniere's disease, there's atypical Meniere's disease, there's cochlear Meniere's disease where there's no predominant vertigo seen, vestibular Meniere's disease where predominantly it is the vertigo which is the symptoms. There's also something very interesting which is called the Lermois syndrome, which most of us during our residency have heard about when we talk about Meniere's disease, which is hearing loss and tinnitus that precedes the first attack of vertigo by months or years, and hearing may improve with the onset of vertigo. Now, most importantly, there's also this particular phenomenon which we call the drop attacks, also called the Tumarkin's catastrophe or the Tumarkin's otolithic catastrophe, where sudden falling happens without any without loss of consciousness per se, and this is basically because the utricle or the saccule otolithic membrane deforms due to the increased pressure in the endolymphatic sac. Now, the epidemiology predominantly favors the frequency of both the ears being less common and is seen more predominantly in females, as shown in the graph here about the rough global statistics in one of the characteristic papers about Meniere's disease, and the peak age of onset is the 5th and the 6th decade. The familial occurrence of Meniere's disease usually sees about 10 to 20%, but it is predominantly proven to be an autosomal dominant trait with HLA-B8 and DR3 with CW7 as the loci that code for this particular disease. Now, if we talk about proposed association, since there's no particular cause that is identified, there is something called secondary Meniere's where there can be a known cause, and it's also termed as the Meniere's syndrome as opposed to the Meniere's disease. And the associations are basically any developmental insults, infections, vascular or dietary or allergy issues, and all of these factors predominantly contribute to endolymphatic hydrops, which then gives rise to the entire spectrum of vertigo and hearing loss and tinnitus with with the oral fullness. Now, the pathophysiology of this particular disease usually revolves around overproduction of the particular, sort of endolymph, and inadequate absorption of the fluid, thereby causing hypoplasia of the vestibular aqueduct and narrowing of the endolymphatic duct sac, which then eventually causes perisaccular fibrosis and leads to most of the symptom complex. And this very, very characteristic loss of epithelial integrity, along with alteration in the absorption and production of endolymph, as mentioned previously, along with developmental anomalies of the sac by itself. Now, increased pressure and rupture of the membranous labyrinth is seen as the reason why there are episodic attacks that we talk about. Here, there's something that's very characteristic that we need to talk about, which is called the Schunnett's theory. The mechanism for clinical manifestation of endolymphatic hydrops is the Reissner's membrane rupture, which happens secondary to the endolymphatic duct distension. Here, the potassium-rich endolymph bathing in the basal surface of the hair cell and the eighth nerve is what is associated, and it's this theory that talks about the repeated hair cell and nerve exposure to toxic level of potassium in the perilymph, causing the episodic vertigo and long-term decline in the auditory and the vestibular functions. The different stages of Meniere's disease need to revolve around the early stages, where we see sudden unpredictable vertigo along with hearing loss and tinnitus, and there's definitely the oral fullness which comes in between the attacks, and invariably there is the middle phase, or the phase where the vertigo attacks are less severe, and the hearing loss and the tinnitus is what takes predominance and becomes worse, along with areas of periodic remissions. Now, there is irritative phase of the attack, which is predominantly seen in the initial part, and then eventually there is the paretic phase and going into healing of the rupture, causing gradual deterioration in the inner ear function, leading to late onset stage, which is usually giving rise to less frequent vertigo in the patient, with more and more hearing loss and tinnitus. Clinical manifestations, as we have previously discussed, predominantly revolve around where the 45% of patients usually have an aura preceding the attack, usually by about a few minutes, and the aura consists of like a tinnitus, hearing loss with oral fullness kind of a spectrum, where most commonly the symptoms can be noticed in 1 year. There is paroxysms of vertigo that can be seen, along with a perception of motion causing nausea and vomiting with the neural mismatch triggers, and usually the attacks last anything between 2 and 8 hours. Now, usually the attacks can worsen with any sudden movement, and the vertiginous disequilibrium usually persists for days up to after when it has shown up. And also, there is fluctuating low frequency sensorineural hearing loss, along with exhibiting sweating and nystagmus symptoms, along with the drop attacks that we previously spoke about. Now, let's talk about the AOHNS criteria for the diagnosis of Meniere's disease, where vertigo, they predominantly include a criteria where there is recurrent, well-defined episodes of rotation or spinning. The duration of these episodes need to last anything between 20 minutes to 24 hours, and the nystagmus has to be associated with the attacks, where there is nausea and vomiting associated, but there is no specific neurological symptom. That is why that's very, very important for us to rule out any associated neurological deficits. Also, the hearing or the deafness, sort of deficit of the hearing is associated. We have to talk about how the hearing fluctuates. We also have to talk about sensorineural hearing loss in this patient, along with progressiveness of the hearing loss, more often than not unilateral in kind. Now, tinnitus here can be a variable symptom, can be usually low pitched or louder, usually unilateral, and predominantly subjective. Now, the AOHNS criteria also talks about something called the possible Meniere's, where there is episodic vertigo without hearing loss or sensorineural hearing loss, which is fluctuating or fixed with the disequilibrium without any definite episodes. Whereas whenever there is probable Meniere's disease, we talk about one definitive episode of vertigo with hearing loss documented by the audiogram at least once, and tinnitus or oral fullness seen in the suspected ear. When there is definite Meniere's disease, we talk about 2 or more definitive spontaneous episodes of vertigo lasting at least 20 minutes, audiometrically documented hearing loss needs to be there at least in one of the occasions, along with tinnitus or oral fullness in the suspected ear. Certain Meniere's disease is the definite Meniere's disease along with histopathological confirmation. Of course, this is usually a diagnosis at death, right? So investigation here would be pure tone audiometry, where there is low frequency hearing loss, very typical rising kind of curve, along with high frequency hearing loss with a flat or falling type of curve. More importantly, we can see speech discrimination score lying between 55 and 85% between the attacks of Meniere's disease, and the special audiometric tests, recruitment test is usually positive, with short increment sensitivity index being more than 70%, and the tone decay test classically being less than 20 decibels in nature. The vertigo test battery in the video nystagmography, there are two different phase testings that we do, where in the acute phase we can see spontaneous nystagmus beating towards the Meniere ear, and chronic phase where we can see the hypo-functioning vestibular hair cells causing the direction to be towards the healthy ear. Now VEMP, which is the vestibular evoked myogenic potential, shows reduced response as expected, and the caloric test generally points towards some sort of a canal paresis kind of picture. Electrocochleography, however, tends to show that the summating potential by actin potential ratio is more than 30%, and classically the glycerol test improves the hearing with the dehydrating agent, usually 1.5 ml per kg that we give orally, and the SDS and PTA before and after shows a proper improvement of 10 decibel or more in two or more adjacent octaves, giving us a classical curve like which has been shown in the diagram here, and this happens to be one of the most diagnostic and sort of prognostic tests for Meniere's disease. In the imaging side, we can see a small or obliterated, almost barely visible vestibular aqueduct, and there is non-visible vestibular aqueduct predicts the saccular hydrops on MRI, while a normal vestibular aqueduct predicts the absence of saccular hydrops. And here in the MRI, we can see, it gives us a very clear idea of how to differentiate between other concurrent diagnoses like vestibular schwannoma or CP angle tumors. And usually we're able to see in the FISTA C, the morphological diagnosis shows an elongation of the saccule, as you can see in the image here, along with non-visibility of the endolymphatic duct and sac, and reduced fluid length within the cochlear aqueduct. Contrast enhanced flare sequencing, generally 24 hours after the intratympanic gadolinium administration or 4 hours after sort of IV gadolinium administration, shows a very classical finding as shown in the diagram here, where there is vestibular endolymphatic space, which is the saccule or the utricle, generally occupying more than 33% of the vestibule, and very, very significant if it becomes more than 50%. The cochlear endolymphatic space or the scala media enlargement usually displaces the Reissner's membrane, and the saccule usually tends to be larger than the utricle here. Now let's talk about the management in a little bit detail, where initially we start off with the conservative measures, and then eventually is when we think about more destructive or more surgical procedures of managing the Meniere's disease patients. So we start off in a step ladder manner, where we talk about the salt reduction diet, we talk about diuretics or vestibular sedatives, and then we go all the way up and talk about surgeries and intratympanic injections, which are a little more to the aggressive management of these conditions. In the treatment aspect, initially we always talk about the Furstenberg diet in Meniere's disease, which is basically a low sodium diet, where he says that there is no need for restriction of calories or proteins of any kind of carbs or proteins, where there is general calorie restriction is not really necessary in Meniere's, and it's predominantly a low salt diet that really helps, along with restriction in caffeine, nicotine and alcohol, and there needs to be avoidance of activities that require good. In the medical management, we talk about symptomatic relief during acute episodes with vestibular suppressants, which have variable antiemetic, anticholinergic and sedative properties. There is IV or IM diazepam that can be used, which causes vestibular suppression and anti-nausea effect, along with anti-inflammatory kind of steroids and IV fluids support in these patients. Management of the chronic phase generally revolves around the vestibular sedatives, vasodilators, diuretics, and elimination of allergens, along with carbonic anhydrase inhibitors and tinnitus masking agents. In non-ablative procedures, we generally talk about the intratympanic injection of steroids. In this particular treatment, there is anti-inflammatory effect of the steroid along with influencing the ion transport channel in the labyrinth. And usually we use dexamethasone 2 milligram per ml concentration, and it is used every week for about 4 weeks with repeated dosaging. And it was Shia in the initial testing of this particular methodology talked about giving a puncture in the tympanic membrane as shown in the image here, and we got very good results in patients as far as symptomatic management of frequency of vertigo in Meniere's disease was concerned. However, disease progression could not be reduced by this particular manner of treatment. Now, local overpressure therapy is heavily talked about in Meniere's disease, where we talk about Minute devices, which is a handheld air pressure generated device that basically makes the patient self-administer a therapeutic pressure pulse inside the ear, causing intermittent low pulse pressures, which brings about relief of symptoms by sort of like a pressure equilibrium kind of a management. So the pressure is delivered with about 20 centimeters of water over 5-minute period with complex pulses, and that requires a ventilation tube to be placed inside the tympanic membrane so that all of the difference in pressure is directly transmitted into the labyrinthine area. Now, conservative surgeries is usually the management that responds better in patients with Meniere's disease with the decompression of endolymphatic sac. There is endolymphatic shunt operation or sacculotomy, cochleostomies, and with fixed surgeries, along with vestibular nerve sections, which are considered as conservative surgery. Now, endolymphatic sac decompression is the method that generally we use quite frequently here in our practice, and there is Portman, who was the first person who described the surgical decompression of endolymphatic sac for Meniere's disease, and talked about how it causes external compression of the sac along with neovascularization of the perisaccular region, causing passive diffusion of the endolymph and creating an osmotic gradient outside of the sac. Now, in the image you can also see a shunt placement in the endolymphatic sac area, where basically it causes a simple decompression and can be extended to wide decompression including the sigmoid sinus, cannulation of the endolymphatic duct, along with endolymphatic drainage to the subarachnoid space with the tube similar to the one shown in the image, along with drainage to the mastoid using silastic sheeting and removal of any extraosseous portion of the sac, as I will show in a little bit. Now, here you can see that we have sort of exposed the mastoid region, and this is the method that we generally use here in our practice, where we create a posterior tympanotomy kind of an approach, and we finally go in and delineate the endolymphatic sac area and take out the osseous margins that cover this particular region and cause a proper decompression of the area very carefully. And after that particular area is defined, we tend to close in with a small muscle graft so that it causes good amount of endolymphatic decompression of those areas. Now, complication of this particular surgery, very commonly we come across very good results in patients who have had endolymphatic sac decompression. However, there are studies that talk about equivocal response in patients who have also undergone a simple mastectomy. So there are a lot of controversial literature about how useful the endolymphatic sac surgery is and whether it's a placebo, and this is something that's very extensively studied in theory. However, in our practice we have found patients having very good amount of response as far as disease progression or even symptomatic relief is concerned in patients who have Meniere's disease. Complication of this particular surgery, we see fenestration of the posterior canal, CSF leak, sigmoid sinus surgery that may happen, any conductive hearing loss, meningitis, and very rarely facial nerve injuries, especially because in our practice we tend to use nerve monitors and ensure integrity of all kinds of all the vital nerves that we encounter during our surgery. Vestibular nerve section, though, now we talk about more end of the conservative management side, and we're going more into the destructive management of Meniere's disease, because most of the patients have very intractable symptoms, and in this case we end up seeing different approaches which can be used for vestibular neurosection. And in this particular complex, we talk about the middle cranial fossa approach, the retrosigmoid approach, translabyrinthine vestibular neurectomy, and most of the times the indication of these particular procedures is to preserve any residual hearing that the patient has, and also relieve episodic vertigo in these patients. Now in this diagram you can see the vestibular nerve section schematically represented here, where there is a retrosigmoid craniotomy and the vestibular nerve section is being followed. And again here also in the image you can see a middle cranial fossa approach, which is giving a very clear idea about reaching the particular area of the vestibular nerve, and then the nerve section that is being done, and then kind of being extracted. And there's also retrosigmoid approach, which can be used for this particular condition, and we tend to open up a U-shaped dural flap, and then through the retrosigmoid area we tend to go in and remove a part of the vestibular nerve. Complication of this particular procedure, of course, are a lot more as opposed to endolymphatic sac decompression surgeries. And here we can see sensorineural hearing loss with complete post-operative headaches are quite frequent. There can be hydrocephalus with continued imbalance in the patient. Very rarely sort of aseptic meningitis can be seen, and there may sometimes also be adhesion of cervical musculature to dura that is exposed. Destructive surgeries, now these are the ones that we also need to talk about, where there is chemical labyrinthectomy and gross surgical labyrinthectomy as well. And chemical labyrinthectomy is carried out by intratympanic gentamicin, extensively talked about in one of the research papers recently published. Low-dose intratympanic gentamicin, which was by Dr. Gayatri and Dr. Rao, where they talk about the intratympanic injection of gentamicin, where there is high vestibular toxicity compared to cochlear toxicity, and the gentamicin tends to gain access inside through the round window membrane, and the concentration of gentamicin in the perilymph of the applied solution reaches up to 5 to 10%, and it's only then that the elimination half-life comes up to about 75 minutes, and it causes complete chemical labyrinthectomy, and specifically causes hearing sparing vestibular symptom relief, thereby reducing the vestibulo-ocular reflux when we do with head thrust, which correlates to initial relief of symptoms. And the weight that we use is about 37 milligrams per ml of gentamicin for this particular procedure, and different delivery techniques are used for this particular carrying out this particular procedure. And we generally can give direct injection, but always the ventilation tube tend to have better concentrations that way. And there's also method of indwelling catheters and sponges over the tympanic membrane. Now physically speaking, surgically we can talk about the surgical labyrinthectomy, and there have been immense amount of papers talking about how labyrinthectomy is the solution for intractable Meniere's disease. And vertigo with severe profound sensorineural hearing loss usually look at labyrinthectomy as a surgical option of treatment. Now there is simultaneous labyrinthectomy and cochlear implantation, which can be the efficient methodology for treatment of vertigo as well as rehabilitation of the auditory system, and that is something that we do here at our center as well. Now complication of this particular procedure, very rarely we see CSF leak from the internal auditory canal. There may be facial nerve injuries, again very minimal since we go for the neuromonitoring method of things, and there is disabling chronic disequilibrium, which is a very unfortunate complication of this particular procedure. But most importantly, cochlear ossification may be seen as a concurrent finding, thereby causing successive cochlear implant may become a challenge in this particular case. And here you can see in one of the patients where we had done labyrinthectomy, and kind of gone in and treated the intractable Meniere's in this patient. So that covers pretty much all the aspects of Meniere's disease in totality. And I hope that a little brief about the different ways of management of Meniere's disease was clear to all our listeners. And if there's any doubts or any queries regarding the disease, the management aspects, or how we go about managing our patients here in the center, feel free to drop us a message or send us a email across any of our social media handles, or drop us questions after the session here, and we will be glad to get back to each one of you and clarify any thing that we can help regarding management of this particular disease, because it's not as uncommon or unheard of these days. Patients are quite aware. Vertigo is a very distressing symptom. Most patients are quite well read. We've had patients who walk in saying that they are Meniere's patients, and it's extensively studied as well. And there are many ways of managing the symptoms as well as managing the disease as a whole from a chronic perspective. So patients really don't have to suffer in silence. So thank you, and we will see